The University of Tennessee Medical Center is our region's only academic medical center. Our mission is to serve through healing, education, and discovery. Our goal is to share the knowledge of our physicians and staff in these health education videos as you make healthcare decisions for yourself and your family.
The first approach I'd like to talk about is called the median parapatellar incision. The old knee replacement incision that was done long ago was a large incision that would go along the quadriceps tendon and patella, and we would push the kneecap to the side and gain entry into the knee to put the knee replacement in place. This results in a lot of pain and scar tissue formation in this area. What we tend to do now, which seems to work a lot better, is we go up along the patella and the patellar tendon, and we go up just a small distance into the quadriceps tendon. We push the kneecap to the side enough to cut the kneecap like we do in a knee replacement, and put what's called a kneecap cap in there, and that allows us to push the kneecap to the side and gain entry into the knee. Now, the advantage of the smaller incision is there's less postoperative pain, there's less scarring, and people tend to rehab better with that. The second approach I want to talk to you about today is called the subvastus approach. Along this quadriceps tendon runs a big vastus muscle. It's one of the main muscles that extends your knee or straightens it out. The subvastus approach, the surgeon goes up underneath the muscle and sweeps the muscle and the tendon away from the front of the knee, allowing access to the knee. Now, this is an approach that actually was used long ago and has been rejuvenated recently for knee replacement surgery. There are benefits to it, and one of the benefits is you're not making an incision up into the quadriceps tendon. So people tend to have less pain in this area postoperatively. The risk involved with it, however, is there's a large muscle mass that we have to move over, and it's got to be moved over enough to gain entry into the knee. Stretching that muscle can cause hematoma formation and stretching of the muscle that can cause postoperative pain and possibly dysfunction. And because of this, and the fact that we need such good mobility in this approach, anybody that's had previous knee replacement surgery or knee surgery in this area is not a good candidate for a subvastus approach. The third approach I'd like to talk to you about is called an intervastus or a midvastus approach. What that involves is the surgeon makes an incision along the patella up into the vastus tendon and then cuts across the tendon this way to split this tendon and once again allow us access into the knee. This tends to be a smaller incision and allows good access into the knee region. However, we're cutting into a muscle, and that muscle, when it's cut, can cause bleeding postoperatively, resulting in a possible hematoma and pain in this area. All three of these approaches have been looked at by the orthopedic community at large, and papers have been written on those. To this date, all three of these approaches seem to be an acceptable alternative in knee replacement surgery. I personally have done all three of these approaches, and I seem to be getting the best results using the medial parapatellar incision. And that's what I most commonly do at the present time. I do think any of these surgical approaches, however, is a good alternative and will result in hopefully a good knee replacement and a happy patient.
We hope you'll join us soon for another medical moment. Visit utmedicalcenter.org or call the Healthcare Coordination Office at 865-305-6970 to learn about services available at the University of Tennessee Medical Center.